Thank you for joining me for the presentation on the treatment options of uterine fibroids. I'm Dr. Rebecca Stern, and I'll be talking about all the different options that are available now for treatment for uterine fibroids. As you can see, there are a multitude of new innovative and technological options available now that have a variety of from non-invasive to invasive treatments. So the treatment that is best for you depends on multitude of things, including the location of the fibroid, the size of the fibroid, and of course the severity of your symptoms. There are also things that need to be taken into account are whether someone wants fertility options to be available, or in other words, if they desire to preserve their uterus, as well as the potential complications and recovery time that each of these procedures take, because obviously everybody has work and things to do with their life. So the spectrum of invasiveness in today's world is fascinating. There's medical therapy that is non-invasive. There's this new procedure called CureWave, which is great. MRI-focused ultrasound. As you can see on this slide, there are again a variety of new treatments available. So watchful waiting is one of the options, and obviously non-invasive. And this is okay. 90% of fibroids are small and asymptomatic, and so we do watch them on a yearly basis to make sure they aren't growing. Once they start to grow or they start to become symptomatic, if we catch them early on, we have some minimally invasive or non-invasive treatment therapies. One of them is non-hormonal that I like to use of recent, and that is an amino acid called lysine, which is, the trade name is Lysteta. It works on the fibroid cascade and decreases the bleeding. It tends to increase your length of cycle slightly, but otherwise is very heavy. It decreases the heaviness of your cycle, so you can go about your day in a normal fashion. One of the other ways that I use to treat minimally symptomatic fibroids is a birth control pill. You say, aren't fibroids responsive to hormones, and you're putting me on hormones. However, it keeps the hormone levels very stable, and therefore usually halts the growth of your fibroids as well. Clearly, birth control pills limit the pain through your cycle and can decrease your bleeding. So the other hormonal therapy that we use is something called Lupron, trade name, and it is used to sort of push patients into menopause. It works on the central acting nervous system and can again stop the hormonal cycles, therefore decreasing the growth. It works for patients who are just about to be in menopause and become symptomatic, so we put them into menopause, which is usually a welcome state for them. As well, we use this to shrink fibroids prior to surgery. There's a limited time period that people can be on Lupron, and therefore it's not used for everybody, because 3 to 6 months of treatment, if you are going to go back to your normal cycling, will not be meet long-term goals, excuse me. So uterine artery embolization is a minimally invasive procedure that was very popular about 10 years ago. It is done in a radiology setting, and the radiologist will implant these polyvinyl particles, hoping to direct them into the vasculature that is feeding your fibroids and making them grow. A lot of times it does its job very well. However, by feeding the vasculature, it kills the fibroid and can present as very painful. As well, these polyvinyl particles can travel and go to distant sites that are not expected or planned for. So endometrial ablation is generally a minimally invasive procedure, and it's more to destroy the lining for the symptoms of bleeding. It generally doesn't treat the fibroid. However, it can treat, again, the heavy bleeding and the symptoms of bleeding and pain. There are many ways to do this. On this slide, you can see two effective methods of heat ablation. There is also freezing ablation. The one on the right is a web which can contour towards any kind of fibroid and burn the lining. And the hope is that in burning the lining, it will scar shut, and therefore the bleeding you will actually be amenorrheic and not bleed, hopefully. Radiofrequency ablation is one of a newer technique as well. It is minimally invasive using a laparoscopy equipment as well as an ultrasound guidance. So the ultrasound finds the fibroid, and as they are looking with the ultrasound, they place the radiofrequency probe into the fibroid and watch the fibroid as it's being heated up with the ultrasound equipment. This is minimally invasive with just the laparoscope, and believe that most of these patients do go home that day or the next day. Myomectomy has come a long way. There are multiple ways to do this. A fibroid is a myoma. There are many names for fibroid. However, medically, myoma means taking out the fibroid. So when I first started practicing, the fibroid was visualized through a hysteroscope if it is in the lining of the uterus, and then was removed with just a forceps. And this was done sort of what we call blindly. I wasn't looking while I was removing it. I was just hoping to grasp it. Then, knowing that this was very difficult, the fibroid is pretty hard, and we were having a hard time getting them out, we started using a cauterized loop. And we could do this while we were looking into the uterus and remove the fibroid that way. This was a little tedious because you had to remove the scope every time you wanted to take the pieces out. More recently, within the past 2 years, there's a new invention that sort of is like a little Pac-Man, and as we're looking in, there's a suction attached to it, and you can take the fibroid out pretty rapidly. This is called a MyoSure, and it's an excellent new technique. Other ways to remove fibroids: obviously, if the fibroid is on the outside of the uterus, you can't remove the fibroid with the MyoSure. So you need to do a laparoscopy or an open procedure and remove the fibroid from the outside. So the laparoscopy, we put gas pressure into the abdominal cavity, and so we can better visualize the uterus and the fibroids. And we were using, we could take out fairly big fibroids using a small port with something called a morcellation, electric morcellator. And this is sort of like, if you could imagine an immersion blender. And so it could cut up the fibroid into small pieces. However, unfortunate consequences have created some limited use for that, and so now we are under investigation or trying to make new techniques to make this be able to do this in a more safe procedure. And I have seen some new procedures recently that are probably going to be on the market in the not too distant future that will help us accomplish the similar procedure, but much safer. The robot is robotic technique. The robot is not operating on you. I talked to some of my patients and we discussed robotic laparoscopy. It is just holding the arms for me to be manipulating the arms and operating on you with multiple ports. So it's an excellent technique. It gives us great visualization and just helps with the laparoscopy. So obviously, if the fibroid is very, very big and we're not using the morcellator at the moment, then an open incision is necessary to remove the fibroid. As well, if the fibroid has grown rapidly in a short period of time, the best technique is to do an open incision. So hysterectomy is the end-all be-all and removes obviously the fibroids and any chance of your uterus growing more fibroids because we are removing the uterus. So a partial hysterectomy, if you look at this slide, does remove just the uterus. It leaves the tubes and the ovaries in place. A total hysterectomy takes out the cervix as well, and certainly a radical hysterectomy will take out not only the ovaries, the tubes, the cervix, and the uterus, but as well some of the tissue lateral to that, and that is usually limited to patients with cervical issues. However, we can do these now hysterectomies robotically, helping with the laparoscope, and patients generally will go home. My patients go home the next day. Some patients go home even that afternoon. Usually done now with 3 incisions. Actually are starting to do single site incisions for robotic laparoscopy as well. We can remove the uterus again through one single port through the belly button as well. We can do a vaginal incision, which is non-painful, and remove the uterus through that. Again, if the uterus grows, or the fibroids grow at such a rapid rate, then an open hysterectomy should be done, and or an incision as well. If the uterus is too large, patients have watched and waited for too long, and we can't possibly get the uterus out vaginally or through these small incisions, then obviously an open hysterectomy needs to be done. And that recovery time is significantly increasing from 1 to 2 weeks to 6 weeks, and certainly hospital stay is again 3 to 4 days usually when that occurs. So again, there's a large variety of invasiveness and many options now available. One of the newer techniques that I find very effective for certain patients is a non-invasive radiologic procedure called a CuraWave, which is an MRI focused ultrasound ablation, and it's a great technique. Patients go on the table, and within an hour and a half to 4 hours, depending on the size of their fibroids and the number of their fibroids, can walk out the door with minimal pain, if any, and again, no real recovery time. So it's a great new technique that we're using as well. So thank you so much for joining my presentation, and I hope it was helpful for you. And if you have any questions, please call the Fibroid Education Center. Thank you.